Thank you very much.
Thank you, Rufesh. Thank you all. And I'll see you soon. Thank you.
Okay, thank you. Thank you. So I'll give a short presentation on. I usually keep two presentation, and I think let me go to my shorter presentation. So this is the topic which I wanted to kind of cover in detail, but I think today I'll just give a very brief overview of my approach to a patient with uveitis, and this is more applicable to general ophthalmologists, not particularly to the uveitis specialist. And I thought the audience will be more of general ophthalmologists. So we get lots of patients of uveitis in our clinic, and what is the best way to approach some of these patients? So usually there is a quite a number of things which are going on, starting with the complaints, you're going with the history, then demographics, history again. If you see, the history can be going on again and again, and then you have the treatment history, then you miscellaneous, then you try to kind of identify some names, and you go for examination and then investigation. Quite a lot of things which are happening in the circle. And I try to kind of make it a bit simpler by saying that you assessing the clinical features after the symptom as with the signs, then allowing you to assess the severity of the uveitis, and then allowing you to say whether it is a healed or active, infective, non-infective, and then only coming at a morphologic diagnosis. So some of those things, probably if you can follow, it will really, really help you. And once again, when you go for the classification, there are different types of classification which people have spoken about. A lot of new things are coming up, but something which should be very simple, anatomical, and all those classification. So with that, I'd like to move to my second slide deck, which is not so detailed. And I just wanted to kind of share on those some pearls, which will directly kind of show. One second, I'll just change it. Okay, so this is the pearls, which I usually keep it as a short presentation. And this is not backed up by the cases, but believe me, every single pearls is backed up by many, many cases, which all of us see. And let me just go into the Zoom thing of that. Yeah. So this is a simple 6 slides where I wanted to share 15 pearls across this. I just spoke about this. We start with the morphologic diagnosis, the pearl number 1. Then we try to give some kind of a nomenclature. Accordingly, we ordered some investigation based on our own learning, based on each case to case, and then particularly come to the infective etiology. Do consider masquerade as and when you are dealing with. These pearls are not in any particular chronological order, but this is just as we walk across the cases of uveitis, those are the things which you have to keep in mind. Pearl number 3 is a dilated fundus examination, is essential in any patient with the disc swelling, or for that matter, any patient of uveitis. And this is again backed up on a lot of cases which were published in literature as well. And one of the cases was optic neuritis, where a peripheral acute retinal necrosis was missed because the doctor never dilated the fundus to check the peripheral retina. So very important in any patient of uveitis, you should try and see a good fundus examination, do a good fundus examination. Fourth, again, there is a good topic by Dr. Padma, where she will highlight about the infective causes. And therefore, it is very important to keep the infective diagnosis, because in those cases, it might be difficult to pull back our diagnosis and go back to kind of the treatment if we kind of commit too early of giving biologics or corticosteroids or immunosuppressive therapy. Regular monitoring and close follow-up is quite critical in some of these patients. You can't just say them, you come back in 1 or 2 years. A lot of these patients, you have to kind of tell them beforehand itself as you start the treatment that they might need to be regularly seen and very closely follow up with you. I typically tell them that this is a long courtship which is going to develop, and a friendship which is going to develop with the patients. And any patient coming to my clinic, usually I tell them that this is not just a kind of a one instance or one encounter. You might have to come multiple times. Then the pearl number 6 is appropriate interventions is right time. And this is again based on the learning where we never did laser retinopexy in a patient of acute retinal necrosis, and the patient ended up getting a detachment of the retina. And there are many, many cases like that, which allowed us to come to this particular pearl. Then think outside the box while we approach a patient of a uveitis. Always keep your eccentric ideas or different things in your mind, and you might be dealing with something. Very recently, I just wanted to share this experience of me managing a patient of retinal vasculitis who have been seen with us for last 10 years from 2009, treated with tubercular retinal vasculitis. And recently, another hospital called me and said, Dr. Rupesh, we wanted to talk to you about your patient. I said, what happened to my patient? He said, the patient is admitted with us with chronic myeloid leukemia. Now, I've been seeing his photo, and which I wanted to show it today, was that I was dealing with chronic myeloid leukemia. Did I miss that diagnosis? Or the patient was stable for last 2-3 years, and I never did a full blood count because everything was stable. But some of those things where that bothers you, is that something systemic which is happening, and are we missing anything? So therefore, keep thinking outside the box in some of this patient where you get some unusual finding. To check all the investigations you have ordered. Sometimes we order the investigation and then we forget to check. It is very, very important to check all those investigations which we have ordered. I missed one of the investigation was syphilis, and we were treating the patient for HIV. In between, the syphilis was ordered, and we were giving him CMV retinitis therapy. And in between, suddenly he developed acute placoid retinitis, which was suggestive of syphilis. And then we went back to the investigation, and we saw the syphilis was positive 2 months before. Probably, if we would have treated, and that this patient would not have developed the macular lesion. To check the medication which the patient is taking and check the compliance of the patient, because a lot of times our patients come with all the story and we don't know whether the patient is taking the right medication and if they are taking it properly or not. So to counsel the patients about the disease and medications, and I particularly take time out of my clinic, spend maybe one lunch with them, kind of thing, that my lunch or my evening, late evening, talking to them in detail, spending time with them. As much time as you spend, they will be more comfortable, they will be more receptive, and something area which I am of late working quite closely with them, psychological counseling of those patients, spending time with them, which probably will help them during their treatment. Be confident before administering invasive therapy, and we talk about the intravitreal Ozurdex in today's world. We have to be super confident that we are not dealing with something disaster in the eye before you inject, because that is a commitment. And before giving a commitment like invasive therapy, just make sure that you're confident, because we have a patient who received intravitreal ganciclovir when I was attending IOIS meeting in San Francisco. And that patient never had CMV retinitis, was having cotton wool spot, but after the injection, the patient developed no light perception. Now, why did it develop? No one knows, but really it happens. And Mr. Pavisho will agree with me about the second opinion. I don't think any Tuesday clinic of his at Moorfields has ever finished before we kind of collect together all the fellows, and 8:30 p.m. when we are all hungry, we are talking about 3 or 4 cases where we don't have any head and flu, and we are talking about what's happening. Right, Mr. Pavisho? Some of those cases which we all remember from your busy clinics in London. Yeah. So, and then important to pay subtle attention to subtle clues, and probably it will take the wisdom of Andre Curie and Carlos Pavisho and the skill sets of Padma and Manisha to get to this, picking up the subtle clues to get to the diagnosis. Look at the patient and not the labs. Yesterday, I got a patient who was shouting at me, "You're not telling me about my labs." I said, "Let me examine the eyes." No, I want to know the investigations you took $600 from me. What happened to that? I said, I will come to that. But the patient was saying, no, just tell me about my investigations. So these are the era we are living in. But I think I kind of fully counsel the patient that I want to examine you, not your labs. Afterwards, I will examine, but first I want to examine you. And last but not the least, as I've already covered, keep a high index of suspicion for any infectious etiology. So with that, I like to stop my sharing.